Hello everyone in CardioMice channel, and today we are discussing controlling diabetes. We already have the 2019 ESC Guidelines on Diabetes and its association with cardiovascular disease, and we have also the 2021 Guidelines on Cardiovascular Disease Prevention. Today we are trying to have a resume regarding the diagnosis and management of diabetes and what's the difference between the two guidelines. Let's start, of course, with the diagnosis. We know from the 2019 guidelines that to diagnose diabetes, we need to have a hemoglobin A1C more than or equal 6.5% and fasting blood sugar more than or equal 126 milligram per deciliter. In order to diagnose, we need to repeat one of them twice or to have both of them in order to confirm diagnosis. We can use also the 2-hour postprandial with a cutoff point 200 or random blood sugar with the same cutoff point, but we need to have hyperglycemic symptoms in order to confirm the diagnosis of diabetes. Some patients are in the gray zone, which we call pre-diabetes. We have the impaired glucose tolerance, in which the fasting blood sugar is normal, less than 126, whereas the 2-hour postprandial is more than or equal 140. And the opposite is impaired fasting glucose, in which the fasting blood sugar is between 100 to 125, but the 2-hour postprandial is less than 140. In this case, we consider it impaired fasting glucose. That's why we sometimes use the oral glucose tolerance test in order to diagnose impaired glucose tolerance per se, whereas impaired fasting glucose can be diagnosed from the fasting blood sugar, but in this case the 2-hour will confirm that this is not diabetes, it is just impaired fasting glucose, which is a pre-diabetic state. The key message in the 2019 guidelines regarding the diagnosis that diabetes should be investigated using fasting blood sugar or hemoglobin A1C, so these are the most two important tools for diagnosis of diabetes. Any cardiovascular patient, we should ask ourselves, is this patient diabetic or not? That's why he should be screened using hemoglobin A1C or fasting blood sugar, and better to have both of them. An oral glucose tolerance test is necessary in specific condition, for example to diagnose impaired glucose tolerance or in case of inconclusive fasting blood sugar and hemoglobin A1C. We have some limitations of hemoglobin A1C, like for example some genetic variants of hemoglobin. In case of anemia, there is overestimation of the ratio of glycated hemoglobin, and unfortunately hemoglobin A1C is unavailable in certain parts of the world, so in this case we would depend on fasting blood sugar and 2-hour postprandial to diagnose diabetes. The 2021 guidelines is nearly the same regarding the diagnosis of diabetes, and it recommends the assessment of hemoglobin A1C and fasting blood sugar in any patient with or without atherosclerotic cardiovascular disease, and that's class 2A. Let's move to the risk stratification. We know from 2019 guidelines that any diabetic patient should be assessed for microalbuminuria in order to identify who is at risk of developing renal dysfunction or cardiovascular disease, and it can be assessed by the protein creatinine ratio rather than 24-hour urinary collection. And resting ECG is indicated if a patient is having both diabetes and hypertension, or if we suspect cardiovascular disease. We know, of course, that diabetes is one of the strongest risk factors for cardiovascular disease, and if it is uncontrolled, it is considered a coronary artery disease equivalent. Echo and coronary artery calcium score and ankle brachial index may be considered to test for structural heart disease or as being risk modifiers, and we discussed this before in the video of risk modifiers, but the risk is less important at the time being than before. And routine assessment for novel biomarkers or carotid intimal medial thickness, we know also from this video that it is not recommended for risk stratification. This famous table is used for risk stratification in patients with type 2 diabetes, but also patients with type 1 diabetes above 40 years. We can use these criteria with them. If a patient is having well-controlled short-standing diabetes less than 10 years with no target organ damage and no additional risk factors, so he's considered to be at moderate risk. If a patient is having diabetes without cardiovascular disease or severe target organ damage, but not fulfilling the moderate risk criteria, for example, duration is more than 10 years, he is considered to be at high risk, and if a patient is having established atherosclerotic cardiovascular disease or severe target organ damage, for example, estimated GFR less than 45, GFR between 45 to 59 with microalbuminuria from 30 to 300, or proteinuria with albumin-creat ratio more than 300 mg per gram, or there is microvascular disease in at least 3 different sites, like microalbuminuria plus retinopathy plus neuropathy. In this case, he is considered at very high risk, the same like patient with established cardiovascular disease. And so most of the patients with diabetes are considered to be at high risk or moderate risk if he is short standing, less than 10 years, and well controlled with no additional risk factors. But if he developed cardiovascular disease or severe target organ damage, he would be categorized as very high risk. In order to decide the appropriate treatment for the patient, we need to know what is the glycemic target that we need to reach in a diabetic patient. 2021 is nearly the same, so it uses a target hemoglobin A1C less than 7% in patients with type 1 or type 2 diabetes. In elderly or frail or those with multiple comorbidities, we may have less stringent hemoglobin A1C, for example less than 7.5, or in certain patients just less than 8% in order to decrease the risk of hypoglycemia, whereas in younger individuals early in the course of type 2 diabetes, patients who are not frail, not cardiovascular, we may have a tighter glucose control less than 6.5. So the general rules that we need to avoid hypoglycemia and excessive weight gain during treatment of diabetes, because the problems that hypoglycemia is associated with increased risk of arrhythmias, myocardial ischemia and death, and weight gain may occur with insulin or sulphonylurea due to the anabolic effect of insulin. So in this famous diagram in patients with type 2 diabetes, after advising the patient regarding smoking cessation and lifestyle recommendation, we have a target hemoglobin A1C in general less than 7%. Let's move now to the most important and most lengthy part of our video, which is treatments. The fact that intensive lifestyle changes with low-calorie diet and also with weight loss of about 10 kg would result in remission of type 2 diabetes in 46% of patients by 1 year and 36% of patients by 2 years. That's why please don't forget, before writing a prescription for the patient, to advise him about the healthy diet, regular aerobic and resistance exercise, weight loss, and smoking cessation. This is not less important than the pharmacotherapy for diabetes. Also, we need to repeat that lifestyle interventions in impaired glucose tolerance can reduce the risk to develop type 2 diabetes, and each additional kilogram loss is associated with 43% lower risk of developing type 2 diabetes. So those patients should be strongly advised regarding the importance of lifestyle modification to decrease the risk of developing diabetes. Mediterranean diet is a cornerstone of any healthy diet that we advise a cardiovascular patient or a diabetic patient with, including vegetables, fruits, legumes, whole grain products, fish, olive oil, and unsalted nuts, and try to advise the patient to reduce the consumption of red meats, especially processed meats, try to avoid it, dairy products, saturated fats, and carbohydrates. And we have discussed the diet and exercise in detail in the specific video. So the key message of 2019 guidelines that reduced calorie intake is recommended to reduce the excessive body weight in diabetics. Mediterranean diet supplemented with olive oil or nuts can reduce the incidence of major cardiovascular events, and moderate to vigorous exercise more than 150 minutes per week is recommended for the prevention and control of diabetes. 2021 nearly adopts the same regarding lifestyle modification, so class 1 to include smoking cessation, low saturated fat, high fiber diet, aerobic exercise and strength training, and reduce energy intake including calories and carbohydrates, especially the easily absorbed carbohydrates like sugars, is recommended to achieve lower body weight, prevent or slow down weight gain. And class 2A, that those motivated to consider weight loss, we advise them to use low-calorie diet followed by food reintroduction, and then try to achieve weight maintenance early after the diagnosis of diabetes. This can help in remission and also help in the control of diabetes, and so the patient is adopting a healthy diet without feeling deprived from the food that he likes. Which medications we are going to prescribe for these patients? The UKPDS study emphasized the importance of intensive glucose lowering regarding cardiovascular risk reduction in patients with newly diagnosed diabetes, and still the evidence supports metformin, one of the classic medication in control of diabetes, which is still the first choice for the majority of patients diagnosed with diabetes. Metformin is one of the famous examples of the biguanides family and still a cornerstone in the treatment of diabetes. We have the famous family of sulphonylureas, which are insulin secretagogues like glibenclamide, glimepiride, or gliclazide. We have also the thiazolidinediones, which has a famous example of bioglitazone, which is less used nowadays due to the risk of salt water retention in cardiovascular patients. We have also non-sulphonylurea insulin secretagogues. The famous example is ribaglinide. We have alpha-glucosidase inhibitors like acarbose, and of course in type 1 diabetes and the refractory stages of type 2 diabetes, we use insulin, either the basal insulin or the short-acting insulin used with meals. But we have also the more recent examples in the last decades, like the GLP-1 receptor agonist standing for glucagon-like peptide, like exenatide, liraglutide, semaglutide, which are mostly subcutaneous medications. We have the dipeptidyl peptidase 4 inhibitors like vildagliptin, sitagliptin, linagliptin, which inhibits the enzyme responsible for breakdown of the GLP-1. We have also the famous revolutionary medications SGLT2 inhibitors standing for sodium glucose transporter 2 inhibitors, which are responsible for inhibiting reabsorption of sodium and glucose in renal tubules like dapagliflozin, empagliflozin, and canagliflozin. The GLP-1 receptor agonists and SGLT2 inhibitors have strong evidence that they lower cardiovascular disease, heart failure, and renal risk independently of glycemic control and baseline metformin use. So they are not just strong antidiabetic medications that result in strict glycemic control. No, they have added effect on the heart and kidney, more evident in those with atherosclerotic cardiovascular disease, heart failure, or CKD, or patients at elevated risk. For example, the GLP-1 agonists reduce MACE, cardiovascular death, and all-cause mortality by 12%, reduce MI and stroke, and also reduce risk of heart failure, and reduce composite renal outcome by 17%. They have a famous side effects of nausea and vomiting, which can be lessened by gradual titration of the dose, and also some of the patients may not prefer them because they are taken parenterally, but still they are strong medications in cardiovascular patients with good cardiovascular outcome. Regarding the SGLT2 inhibitor, reduce also the MACE, which stands for the major adverse cardiac events, by the way, by 14%, and reduce incident heart failure and hospitalization and cardiovascular deaths by 24%, because it doesn't act only on the glucose reabsorption, also on the sodium reabsorption, so it reduces salt water retention. That's why it has a favorable effect on the heart failure prognosis, and reduce renal composite endpoints by 44%, and these benefits may be related to cardiorenal hemodynamic outcomes, not just for atherosclerosis or glycemic control. The famous side effects of these medication is the increased incidence of genitourinary infection. Also, one trial showed an excess of amputations and fractures with canagliflozin, but none of the other trials showed these adverse effects, and rate of DKA is generally low because there was some concern that the diabetic ketoacidosis may be more common with SGLT2 inhibitors, but this concern is now abolished with the more present trials. We consider DPP-4 inhibitors to be neutral medications on the cardiovascular outcomes, as 4 trials in patients with diabetic and cardiovascular disease or at high risk for cardiovascular disease showed non-inferiority but not superiority regarding cardiovascular risk. But we have a famous medication of them called the Saxagliptin, which was investigated in the SAVOR-TIMI trial, showing an increased rate of hospitalization for heart failure without increase or decrease in the rate of ischemic events. That's why the most commonly used DPP-4 inhibitors are the Vilda, Sita, and linagliptin, but Saxagliptin is not used frequently nowadays. The American Diabetes Association and European Association for Study of Diabetes recommended that metformin should be used as the first-line treatment in any diabetic patient, but the ESC Guidelines in 2019 recommended that GLUT2 inhibitors and GLP-1 agonists may be used without metformin in patients with diabetes and cardiovascular disease, patients with diabetes and at high risk of cardiovascular disease. So what should I follow in order to prescribe a medication for a diabetic patient? There was a subset of the American and the European associations to form a consensus report with the ESC guidelines, and recommended that patients with type 2 diabetes plus cardiovascular disease or heart failure or CKD should be treated with GLUT2 inhibitor or GLP-1 agonist independently of background therapy or glycemic control or individualized treatment goals. So the ESC guidelines emphasize in 2021 that if a patient is having type 2 and atherosclerotic cardiovascular disease class 1, to use GLP-1 agonists or GLUT2 inhibitors due to the strong evidence of cardiovascular and renal outcomes, and the class 2A to use metformin unless contraindicated. So here GLP-1 and GLUT2 inhibitors are superior to metformin. If a patient is having type 2 diabetes and heart failure with reduced ejection fraction, class 1 also to use GLUT2 inhibitors per se due to its effect to reduce the heart failure, hospitalization and cardiovascular deaths. And in patients with type 2 and CKD, we can use GLUT2 inhibitors down to creatinine clearance of 30, which would help to lower the progression of chronic kidney disease. If a patient is having diabetes and target organ damage, it is class 2B to use GLUT2 inhibitors or GLP-1 agonist, but here the evidence is not strong enough to have a class 1 or class 2A recommendation. But if we excluded these comorbidities in a diabetic patient, class 1 is for metformin to be used in this patient's prescription, and the class 2A to select GLUT2 inhibitors or GLP-1 agonist if you estimated that the patient is having high risk for cardiovascular or cardiorenal outcomes using the advanced risk score or DIAL model. We remember the advanced risk score, which predicts the 10-year cardiovascular risk and also predicts the fatal and non-fatal cardiovascular risk, and we remember the DIAL model, which predicts both 10-year risk and lifetime risk for cardiovascular events and cardiovascular death. So we can use this risk score to estimate the patient's risk profile in order to decide whether to choose metformin or choose GLUT2 or GLP-1 agonists. So the conclusion of 2021 regarding the pharmacotherapy is that metformin should be considered but not mandatory first line in patients with cardiovascular disease or target organ damage, and the initiation of metformin in such patients should not delay the initiation of evidence-based GLUT2 inhibitors or GLP-1 agonists. So it depends on the clinical assessment, on the risk profile on the patient and the comorbidities to decide which one to choose. What to do in patients with type 1 diabetes? The diabetes control and complication trial showed the importance of tight glucose control since the early diagnosis of this disease to reduce the risk of both microvascular and macrovascular complication, and 6.5 years of intensive diabetes control was associated with lower all-cause mortality. So glycemic targets is still nearly the same in type 1 diabetes with about 6.5 to 7.5, so we can use also an approach of less than 7% for long-term glycemic control. Metformin did not show any lower progression of carotid intermediate thickness in patients with type 1 diabetes. That's why it is not recommended in type 1 for this indication. Some doctors may use GLUT2 inhibitors with insulin in order to complement the glycemic control. That's why sometimes GLUT2 inhibitors have a therapeutic role in type 1 diabetes. What about the famous issue of a patient having both diabetes and hypertension. The 2019 addressed this issue and it recommended RAS blocker to be the first choice in any hypertensive patient with diabetes, especially in presence of complications like microalbuminuria or left ventricular hypertrophy. Still, the combination is preferred, the same as in the 2018 guidelines and also the same recommendation in the 2021 guidelines. Patient with impaired fasting glucose or glucose tolerance RAS blocker is class 2A and should be preferred to beta blockers or diuretics, and the effect of GLP-1 agonists or SGLT2 inhibitors on blood pressure should be considered. We know, of course, that some of the SGLT2 inhibitors have been shown in trials to reduce the blood pressure, and so they improve both glycemic and blood pressure control. What about a patient having diabetes and dyslipidemia? Also, they recommended that the patient, if at moderate risk, an LDL target less than 100 mg per deciliter, at high risk, LDL target less than 70, at very high risk, LDL target less than 55, and in the 3 recommendation we have also the addition of at least 50% reduction from the baseline LDL. Statins should be considered in any patient with type 1 diabetes and the high cardiovascular risk regardless the baseline LDL level, and statins may be considered in asymptomatic patient with type 1 diabetes beyond the age of 30 years, but this is class 2B. So finally, after we have explained in this video, this diagram which was published in the 2019 guidelines summarizes the approach to pharmacotherapy. If you are dealing with a drug-naive patient, we need to assess whether he has atherosclerotic cardiovascular disease, high or very high cardiovascular risk. If it is present, so we need to start with SGLT2 inhibitors or GLP-1 agonist. If still hemoglobin A1C above target, add metformin. Still above target, we can consider a combination, adding DPP-4, basal insulin, sulphonylurea, or thiazolidinedione if not in heart failure. If a patient is not having these comorbidities, so we can start with metformin. If hemoglobin A1C above target, we can add DPP-4, GLP-1 agonists, GLUT2 inhibitors, or thiazolidinedione. Still above target, we can consider combination, adding other agents. And if still above target, we can consider sulphonylurea or basal insulin. Basal insulin has a lower risk of hypoglycemia than short-acting insulin, and later generations of sulphonylureas is preferred because it has a lower risk of hypoglycemia. If you are dealing with a patient who is already on metformin and he is having high cardiovascular risk or cardiovascular disease, consider GLUT2 inhibitors or GLP-1 agonists, and if still hemoglobin A1C above target, consider combinations or other agents. If the patient is not having this risk profile, so continue metformin, and if hemoglobin A1C above target, consider the other agents. Still above targets, consider combination. Still above target, consider sulphonylurea or basal insulin. So our take-home message today from this video is that diagnosis of diabetes depends mainly on fasting blood sugar and hemoglobin A1C, plus minus oral glucose tolerance test in specific situations. Target glycemic control is 7% in general, more or less according to the patient's profile and risk. And the cornerstones of pharmacotherapy are SGLT2 inhibitors and GLP-1 agonists, especially in high-risk patient or very high risk, and metformin, one of the classic medication that is still a cornerstone in pharmacotherapy. Thank you very much for watching this video, and wait next week for antithrombotic therapy.